Good morning, everyone, and a very warm welcome from Peter Rice and myself, Linda-Gail Becker. We are the co-chairs of AIDS 2018, and it is our great pleasure to welcome you to this large and intimidating room for an abstract-driven session, but correctly so, because this is the co-chair session. It's something we started in 2017, and it was because we felt it was quite important to bring if you like, a potpourri of interesting, relevant, or unusual science to a session where that could be really enjoyed and interrogated as the essence of the conference. So this is our second, and we hope you will thoroughly enjoy it, and thank you for being present. I'm going to hand over to Peter at this point.
Thank you, Linda-Gail, and thank you and welcome again to every one of you in the room. I think for sake of time we should get started, and the first series of abstracts is really related to increasing the effectiveness of ART, and it's a pleasure to introduce the first speaker, Brittany Barker from the BC Centre for Excellence in Vancouver in Canada, who will be speaking on the importance of methadone therapy in the context of managing people who use drugs. Brittany, pleasure to have you here.
Okay, I'm the first, so this is good. I like being first. Just everything has to work. Okay, great. We're good? Okay, well, hello. I'm honored here to be here to give you my talk, and thank you for all coming to listen to my presentation. I'm a PhD candidate at the University of British Columbia, as well as a research associate at the BC Centre on Substance Use in Vancouver, BC, Canada, which is where this study was undertaken. I have no conflicts of interest to declare, but I would like to humbly acknowledge that my work takes place on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. So my outline is fairly straightforward for my presentation. We'll do some background, study rationale, then I'll tell you about the access study, methods, and then I'll get into the results and our discussion. Okay, so some background to start. It's well known that among people living with HIV, an elevated plasma viral load drives HIV disease progression and risk for onward viral transmission. It is also well established that a viral load of 1,500 copies or above is associated with an increased risk for viral transmission. However, to date, most research in this area has focused on temporary increases in viral load, often to levels that may not increase risk for onward viral transmission. Further, people who inject drugs are disproportionately at risk for HIV, who now account for more than 1/4 of new HIV diagnoses in North American and more than 80% in countries experiencing outbreaks in HIV, such as Eastern European and Central Asian countries. Despite being a key population living with HIV, people who inject drugs continue to experience individual, social, and structural barriers to accessing and being retained in HIV treatment and care. And while ongoing illicit drug use has been shown to increase time among 1,500 copies, the threshold, I want to emphasize that it may not be drug use per se that is driving this relationship with higher community viral load. As we've previously demonstrated in our study setting, that when you adjust for socio-structural factors such as access to addiction treatment, housing, employment, etc., that this relationship becomes non-significant. Opioid agonist therapy like methadone or buprenorphine are the standard of care for treatment of opioid use disorder in Canada and elsewhere, regardless of HIV status. Methadone has been shown to reduce incidence of HIV among people who inject drugs, provided it is done so in a low threshold format. Similarly, among people who inject drugs and also living with HIV, methadone has been shown to promote and both initiation and adherence to ART. So a key rationale for this study was to estimate the effect of methadone maintenance therapy, or MMT, engagement on time with a viral load above 1,500 copies, thus seeing if engagement in MMT curbs onward viral transmission in the community. And although engagement in MMT has been associated with lower HIV seroconversions and among HIV-positive individuals increased CD4 counts, the link between methadone maintenance therapy and HIV transmission risk has not yet been established. So in the present study, we sought to longitudinally examine the relationship between engagement in a low-threshold methadone maintenance therapy program and amount of person time with a heightened HIV transmission risk, i.e. a viral load over 1,500 copies, among a long-standing prospective cohort of people who use drugs living with HIV in Vancouver, Canada. These analyses use data from the AIDS care cohort to evaluate access to survival services, or ACCESS, which is a community-recruited, ongoing prospective cohort of people living with HIV/AIDS who also use illicit drugs, in addition to or other than cannabis in Vancouver. Our study has been ongoing since 2005. Study participants complete interviewer-administered questionnaires and provide blood samples for serologic analysis at baseline and semi-annually thereafter. At baseline, participants provide their personal health number, which is a unique identifier issued for medical billing purposes to all residents of British Columbia. This allows us to link our data with the drug treatment program at the BC Centre for Excellence in HIV/AIDS, which is a confidential data repository for all HIV-related treatment and monitoring throughout the province, including plasma viral load, CD4 counts, and specific antiretroviral agent dispensation records for each participant. I want to emphasize that the drug treatment program provides no-cost HIV treatment and care, including all medications, to people living with HIV/AIDS in British Columbia through the province's universal medical system. So we included all individuals who were enrolled between December 2005 and November 2017 who were either ART exposed at baseline or the observations after they initiated ART over our study follow-up, as well as had 2 viral load measurements. Our outcome variable of interest was amount of person time measured in days exceeding a viral load of 1,500 copies per milliliter of plasma in the previous 180 days. We calculated our outcome variable using consecutive pairs of viral load measurements and then estimated the proportion of time between to recreate viral load history based on a method established by Marks and colleagues. So if 2 measurements were above the threshold, we assumed the entire 180-day period between was above 1,500. Similarly, if both were below, we assumed that the time between them was also below. If anybody is interested in how we did specific calculations for differing viral load levels, you can come find me after the talk and I'll walk you through it. It's very interesting. The explanatory variable of interest was self-reported engagement in methadone maintenance therapy at any point in the previous 180 days. And we used generalized estimating equations, or GEE, to allow us to incorporate multiple observations from the same individual and account for the non-independent nature of these observations. Between December 2005 and November 2017, we recruited 867 ART-exposed participants with at least 2 viral load measurements. These participants contribute to 9,062 observations, which is equivalent to 4,532 person years of observation. The majority of the sample identified as male, with 394 participants reporting engagement in methadone at their baseline study visit, and 522, or 60% of our sample, reporting being engaged in methadone at some point over our study period. Lastly, 583 or 67% of our sample had at least one period with one or more days of viral load over 1,500 copies. So both high levels of engagement in methadone, but also fairly high levels of viral load above the threshold was observed among our sample. After adjustment for age, gender, daily crack cocaine use, and CD4 count, and residing in the downtown of Vancouver, which is a post-industrial neighborhood with large open drug market and high levels of illicit drug use, poverty, and HIV infection, engagement in methadone maintenance therapy was independently associated with a 30% reduction in the risk in the amount of time with an HIV viral load over 1,500 copies. Of note, adherence to ART was not included in our final multivariable model here, as we've proven elsewhere that lower adherence to ART mediates the relationship between methadone maintenance therapy, engagement, and viral load. So among the cohort, we observed that periods of heightened HIV transmission potential were common, with over 2/3 of our sample having at least one viral load measurement over the threshold of 1,500 copies, over a median follow-up duration of 60 months. On average, participants spent 19% of observation time over the threshold. What we found was that engagement in methadone maintenance therapy was associated with significantly less time above this threshold among our large and long-running cohort of people who use drugs living with HIV. Further, I think it's worth mentioning that by estimating the proportion of time spent above 1,500 copies longitudinally in the present study, this is a more nuanced and useful metric for measuring risk for onward viral transmission potential in the community than previous, more crude measurements of viral loads at one point in time and then extrapolating community risk. So what does this mean? These findings suggest that low-threshold methadone maintenance therapy is an effective intervention in not only halting disease progression, but also curbing onward viral transmission among this key population. Further, these findings demonstrate the important role of evidence-based addiction treatment in optimizing individual and community-level impacts of antiretroviral therapy among HIV-positive patients with comorbid opioid dependency. Efforts to address barriers to the use and availability of methadone maintenance therapy will likely improve HIV outcomes and reduce new infections among this key population and should therefore be prioritized. Barriers to prescribing MMT or opioid agonist therapy in general in the United States are considerable, with heavy restricting and waiver requirements. And Russia, where methadone is illegal, where naloxone and detox are the preferred treatment options. In the wake of the opioid crisis, Canada has made significant changes to OAT prescribing, removing the MMT waiver restriction for physicians and moving buprenorphine as the first-line treatment to be prescribed by a range of healthcare practitioners beyond traditional physicians due to its higher safety profile. Lastly, our findings support the urgent scale-up of access to evidence-based addiction treatment and the benefit of co-locating low-barrier HIV treatment and care with addiction treatment services as a central component to the effort to control the global pandemic among HIV positive people who inject drugs. And thank you, and I would like to first acknowledge my co-authors, Dr. Kit Fairgrieve, Keith Ahmad, Thomas Kerr, Jeannie Shoveler, Julio Montaner, Evan Wood, and particularly Dr. Malloy, who is the senior author on this study, as well as the PI of Access. And of course, Access study participants who share their expertise and valuable insights with us, the BCCSU staff and research support, our funders, particularly the Canadian Institutes of Health Research, as they support my doctoral studies, and IAS for generously supporting my travel to this beautiful city to give my talk to all you beautiful people this morning. Thank you, and I'll take any questions.
Thank you very much, Brittany. And just to say that we have been talking a lot about the need to engage youth in the HIV response, and I think it also goes for young scientists like yourself. So
Thank you. I'm young.
Thank you for being here. So the talk is open for questions. Are there any questions at the microphone? It's hard to see from here, actually. I think there's somebody moving up to the microphone, number 4.
Yeah, here we go.
It's hot up here.
Yeah.
Number 5, if you go to
Number
number 5.
No. Okay. So yeah, I just want to. Is there? Oh, here you are. Sorry for missing you. Number 2.
There were the microphones in the back, so I had to go forward. Now, thank you for your excellent talk. I'm Maria Prins from Amsterdam, and we're always promoting not only methadone but also needle and syringe programs. And I was wondering whether you also evaluated the effect of needle and syringe programs and the effect on the drop in viral load.
Yeah, for sure. As I said, our study's been ongoing since 2005, and so Vancouver went through a pretty significant period where we went from a needle exchange program to a distribution model, and we have studies that showed the kind of moderate success before and then the much improved success after we did needle exchange or needle distribution after.
But was you able to evaluate also in this study the effect of needle exchange program or for combined methadone?
No,
Okay.
no, sorry, not on this one.
Okay, thank you.
Okay.
Just one quick question. In the slide, you alluded to some barriers in the U.S. I'm not aware of barriers to methadone or buprenorphine, and they're widely available in the U.S. What barriers are you referring to in the U.S.?
So I mean, I am Canadian, but for doctors to be able to prescribe methadone, they have to do an extensive waiver requirement so that they're able to prescribe it, which has been researched that it's a bit of a barrier to.
No, that's for buprenorphine, but not for the methadone are dispensed in methadone clinics, but their clinics are widely available, and doctors who are licensed to prescribe methadone working in the clinics have no barriers whatsoever.
Yeah, I think it's just the licensing is that we're talking about.
Okay. Okay. Well, I think also for sake of time, thank you, Brittany. So our next speaker will be Velefi Okello from Swaziland, and she will be presenting results from the MaxArt trial on universal test and treat. Pleasure to have you here.
Good morning. Thank you for the opportunity to present on our experience as the Kingdom of Eswatini, previously called Swaziland. I'll give a background context of our study. At the IAS conference in Rome, in the HPTN 052 study, announced the results of treatment as prevention, which for this presentation I'll refer to as Early Access to Art for All, or EAAA. From the study, from the HPTN 052, we learned that not only does EAAA have the potential to decrease the number of new infections, it also means that earlier treatment will allow people living with HIV to not wait to start ART. So following these results from this trial, the HPTN, we saw a number of randomized control trials coming up in the world to investigate the effectiveness of EAAA in generalized populations. Globally, we could see the debate changing from whether or not early access to art for all should be implemented, but rather to how countries can scale up treatment strategically and efficiently to change the HIV prevention landscape. So in Eswatini, the Ministry of Health, we saw the opportunity to test the implementation of early access to art for all. And along with our partners in the MaxArt consortium, we designed an implementation trial to provide empirical evidence to assess feasibility, accessibility, affordability, and clinical outcomes, and even scalability of implementing a national early access to art for all strategy through our routine government-managed health system delivery system. We designed a stepwise study, which we felt was the most pragmatic approach for a real-world evaluation of a series of delivery interventions within our government-managed health system. So in the study, we selected 14 health facilities in the northern Cohort region, which were paired according to geographical nearness and patient volumes, so that we had a mix of high volume and low volume sites. So the study started in September 2014, and the paired facilities were transitioned every 4 months for 36 months, up to the end of the study in August 2017. The control arm was the standard of care. At that time, these were the existing national treatment guidelines at that time, and the intervention arm included sites that transitioned to offer antiretroviral therapy regardless of CD4 count, or what we call EAAA. It is worth noting that during our study, there were guidelines changed. That is from 2014 to 2017. They changed twice. The first change was in December 2015, December 2015, when the guidelines changed from CD4 eligibility of 350 to 500 CD4 cells. And then in October 2016, the country changed the guidelines to test and start. So we selected 2 primary endpoints for the study, retention and viral load suppression. But today we'll present the results on the retention, because further analysis is still going on with the viral load results. Unlike other test and treat trials, which were looking at HIV incidence in the population, in the early access to art for all study, we were only looking at retention and viral load suppression among the patients that we were following in the public health system. Survival analysis was used to analyze the data. Over the 3 years, we enrolled 3,405 clients into the MaxArt trial across the 14 facilities, as we can see here. If you look at our baseline study population, we see that 60% of our study participants were enrolled in the standard of care, while 40% enrolled during the early access to art for all period. The demographic characteristics did not vary meaningfully between the 2 study arms, with the exception of sex, whereby 34% and 44% of the participants enrolling during the standard of care and early access to art phase were male, respectively. But this trend is consistent with the demographics for clients on antiretroviral therapy that we see in the country as well. When considering the clinical characteristics, we did see some variation between the 2 arms. We found that 79% of the participants enrolled within a year of HIV diagnosis in the early access to art arm or intervention phase, as compared to 49% in the standard of care arm. We also saw 56% enrolling with baseline CD4 of less than or equal to 350 cells per microliter in the early access to art arm, compared to 44% in the standard of care arm. In this analysis, we considered a client retained if they didn't die, they didn't stop treatment, and were seen in the facility within 90 days of the study end date or transition date. We censored the standard of care clients at the time of clinic transition. We found that 60%, we found a 60% increase in retention under the early access to art arm, with a follow-up period of up to approximately 2 years. Looking closer, we found that there was a high 12-month retention rate of 86% under early access to art for all as compared to our standard of care. So just a reminder that MaxArt was a multidisciplinary study that applied a strategic mix of research methodologies, including implementation science research, social science research, economic evaluation, and cost-effectiveness modeling, and incidence modeling. So as part of our economic evaluation, we conducted a bottom-up and top-down costing exercise to assess the difference in costs between the two arms. What we found very interesting after considering the retention results was that there was no significant difference in costs. While we are retaining more patients under the early access to art for all arm, the cost per patient per year in the early access to art was similar at $215 per patient per year versus $219 per patient per year in the standard of care. For Eswatini, this was important for our government to understand the cost implications as we shifted from the standard of care at that time to early access to art for all as our national guidelines. So in summary, we were pleased to see the strong retention findings under early access to art for all, since this was a concern that was raised earlier on when considering a large scale up of test and treat in a real-world setting. In addition, the improved retention under early access to art was achieved while antiretroviral therapy patient cost of care were comparable with the standard of care. I would also like to highlight that there's further analysis being done on the viral load results, but there are the preliminary findings are quite interesting. MaxArt was a health systems implementation study, and we have learned and applied a number of the important lessons for our health system from this trial for the rollout of Test and Start in our country. So I also wanted to quickly mention that we have a number of other sessions that, including a satellite session where that will happen tonight at 6:30 to 8:30 p.m. in room 102. This is where we'll be presenting the overall results of the study, in addition to the clinical results, including findings from the cost analysis, social science research, and the assessment of the role of community stakeholders. And my Honorable Minister of Health of Eswatini will also speak about the lessons learned at that, during the study in the country. So these are the sessions that will be taking place. May I take the opportunity to thank our generous supporters and partners in the MaxArt Consortium for all the excellent collaboration over the past 7 years to support Eswatini's efforts to realize an AIDS-free future. And on behalf of the MaxArt Consortium and the government of the Kingdom of Eswatini, I would like to thank our health workers and community members in Eswatini who actively participated in the implementation of this work. I thank you very much.
Thank you very much. The paper is open for questions. As we wait for somebody coming to the microphone, I had a question up here, sorry. I recall that in the abstract you did mention that there was a benefit also with respect to viral load suppression.
Yes.
Can you speak to that maybe?
Yes, so with the viral load suppression, from the preliminary findings that we have, we found that there was a significant difference between the standard of care and the intervention arm. At 4% at the standard of care compared to 79% with the intervention arm. So here there is an issue which we are looking at. We would like to go deep into the results, to the data, because there is a possibility of some viral load having been missed for the standard of care, because viral load in the country has not been widely available. But through the study, there was an attempt to support the facilities to make sure that they conduct the viral load testing during the intervention arm. So we hope we'll come up with more interesting findings on that.
Okay. And maybe if another question I had is here's somebody coming to the microphone? Okay. Microphone number 2. Please introduce yourself when you ask the question.
Hi, Nancy Nancy Padian, UC Berkeley. Great presentation. I just wanted to check one thing, and that is what you were saying, that it looks like the differences between the treatment and the control are attenuated over time. Is that right? So it starts out that the treatment is 60% higher retention. I'm not sure at what point in time, but at 12 months, they're closer, right? It's 86 versus 80. The difference in retention at 12 months. So the first one, it's how many months follow-up was there when you did your first assessment to see whether and recognize that treatment had 60% better reduction? That was after how long? Sorry, I'm trying to get an idea about whether the durability of the result and whether it's attenuated over time.
Okay. With retention, we tend to find that during the earlier times of soon after enrollment of our clients, the retention is a bit higher. It's much higher than as you go down. So there is the tendency that you may find that the retention over time starts to differ quite a lot. So.
Are the differences between the arms greater over time or less over time?
Over time, the retention between the two arms tended to increase. Yeah, tended to increase over time.
Okay. I don't see any other people at the microphone.
No, there's
One last question. Please introduce yourself. No.
Good morning, Nishan Patan from Cape Town, South Africa. So it's very similar to the person that just posed the last question. You mentioned you've got improved retention in care, and it's something that we're struggling with in Cape Town in South Africa. So I was interested, your retention in care at 12 months, and also how long will you be tracking these patients that has enrolled for early access to ART, to kind of get a sense of when they are starting to drop off, because our patients tend to start defaulting on treatment after 12 months.
Okay. So there were different, the patients who were being followed up had different timelines of follow-up because of the stepwise design. You find that some had been followed up for a shorter time, while others had been followed up for longer. So the ones who had been followed up for a longer period, where there was up to 2 years follow-up from the time of initial enrollment, compared to some who had been followed up for a much shorter period of time.
Okay. Thank you very much. Okay, it's a pleasure to introduce the next speaker, Anne Goddard from the Population Council, who will be speaking on men's HIV risk profiles in South African Dream site. And I'll let you explain the complexities of your methods in your talk.
Thank you. Good morning. Thank you very much to the co-chairs for inviting us to present at this session. So I'm going to be sharing our experiences in developing HIV risk profiles for more strategic context-specific programming and evaluation. So there's a critical need to reach more men with HIV prevention and treatment services. As I'm sure most in the audience know, men have lower testing and treatment uptake than women across sub-Saharan Africa. They also consequently have higher AIDS-related morbidity and mortality. In particular, there have been intensified efforts in the last few years to reach men at highest risk of acquiring and transmitting HIV. There's also been a recent focus on male partners of adolescent girls and young women. For example, the DREAMS partnership, which I'm sure most of you have also heard of, is a PEPFAR-led initiative which aims to substantially reduce new infections among young women in 15 countries and counting. And DREAMS includes a strategic focus on characterizing their male partners and getting them into services. So reaching the right men requires a context-specific understanding of groups of men most at risk to inform differentiated programming and evaluation. Latent class analysis, or LCA, can generate sophisticated data-driven profiles. It's a way to uncover hidden groupings in the data, or latent classes, and it can include demographics as well as attitudinal and behavioral indicators. LCA really builds on the benefits of other quantitative and qualitative approaches. For example, a quantitative approach would be audience segmentation, and a qualitative approach could be ethnographic work to build typologies. However, LCA, we think, provides an important opportunity to develop a complex picture using a large sample. And it's rarely been applied in HIV prevention in low and middle income countries. However, it's now more possible than ever due to advanced software packages available, and it's also not overly complex to perform. So our study setting was Durban, South Africa. We conducted a survey with almost 1,000 men ages 20 to 40 years old in 2 informal settlements where DREAMS was being implemented. And we recruited men from community venues as well as HIV service sites from May to September 2017. So who were the men? They were 28 years old on average, only 16% were married or cohabiting, about half had achieved a secondary level of education, and 21% a university or college or technical college degree. 39% were unemployed, and the rest were employed in a range of occupations. And what were their relationships like? In terms of the number of sexual partners in the last year, about half had had 2 to 4 sexual partners in the last year, and about a quarter had had 5 or more partners in the last year, so very high numbers of partners. In terms of transactional relationships, we asked about paying for or providing goods or services mainly to start or stay in a relationship. And we distinguished between low-end transactional relationships, things like providing cash, a meal, or transportation, versus high-end, paying for things like a partner's rent, debt, or school fees. And you see that 44% of men had engaged in low-end transactional relationships. This is in the last year. And 12% had engaged in high-end. And finally, we found that 25% of men endorsed highly inequitable gender norms. This was measured by the GEM scale. An example item is sometimes a man needs to put a woman in her place. So we identified 4 distinct HIV risk profiles. 2 of the groups were younger men, one of which was moderate risk, 36% of the sample, and the other of which was high risk, 24% of the sample. 2 of the groups were older men. One was at lower risk, or very low risk actually, 20% of the sample, and the other was at high risk, again, 20% of the sample. So starting with the younger moderate risk group, they were the youngest, had the youngest or the lowest average age at 23 years. They were almost all unmarried. They were largely unemployed. I think about 3/4 were unemployed, despite being the most likely to be university or technical college grads. And they had a high number of partners, but they tended to be same-age partners, so low age difference, and otherwise they had moderate levels of risk. The younger high-risk group were a bit older, at a mean age of 27, and were also unmarried. They were likely to be informally employed in a range of occupations. And in contrast to the moderate risk group, this group was high risk across the board. In particular, they had many low-end transactional relationships and very high gender inequity. Moving to the older low-risk group, they were 30 years old on average and tended to be married. They were also informally employed. And they had very low levels of risk across the board. So low number of partners and very minimal transactional relationships and very low gender inequity, that is, high gender equity. Finally, the older high-risk group were 36 years old on average, also married or cohabiting. They were more likely to be formally employed than the rest, but still had a range of occupations. And they had a high number of partners with a high age difference, as well as many high-end transactional relationships. So taking a closer look at some of these data points. So we can see that the younger high-risk group had the highest number of partners. 42% had 5 or more partners in the last year, versus only 7% for the older low-risk group, which is still a fairly high level. So here we're looking at the man's mean age in the light blue line versus the age of his last 3 partners in the dark blue line. And we can see that, that the gap increases as men get older, with the starkest gap among the high-risk groups, particularly the oldest group. And finally, this is looking at the endorsement of highly inequitable gender norms. And we can see that the younger high-risk group had substantially more inequitable gender norms than the other groups, and that the older low-risk group had very low endorsement of gender inequitable norms. So now I'd like to turn to look at levels of HIV outcomes or HIV service uptake by latent class membership. So essentially what we're doing here is we're taking the latent class variable that we created, which has the 4 levels, and we're looking at service uptake, recent service uptake for each of those levels, and we're looking at sort of any statistically significant associations. So we would clearly want the higher risk groups to be using services more than the lower risk groups. However, we see that across the outcomes, the higher risk classes were less likely or no more likely than the lower risk classes to use HIV services. And the largest difference we saw was in having received VMMC in the last 5 years, with 42.6% of the younger moderate risk group receiving it versus less than 20 for the other groups. However, this still represents a very good VMMC uptake. Also, HIV treatment literacy score, which we assessed with a composite of 5 items assessing correct knowledge about the attributes and benefits of HIV treatment. It was highest in the older low-risk group and lowest in the younger high-risk group, which we prefer to be flipped. And then testing for HIV and currently taking antiretroviral treatment did not differ significantly across the board. So what are the implications of this work? We think that latent class analysis like this can enable differentiated programming that's tailored to the context, and it's clearly, it's not only applicable to populations of men, but pretty much any population you'd be working in. It also enables monitoring of program outcomes by latent class membership, so you can track HIV testing, VMMC treatment uptake over time for each of the latent classes to help you understand who you're reaching over time and with what services. And finally, it enables evaluating intervention impact by latent class membership. And by way of example, we're in the middle of conducting our round 2 survey to evaluate intensified service outreach to male partners of young women via DREAMS, so stay tuned for that. And I'd like to acknowledge funding support from the Bill and Melinda Gates Foundation, our local research partner Epicenter, and support and collaboration from a number of South African partners. Thank you.
Thank you very much. Paper is open for questions. Microphone number 4. I think there's somebody. Yeah, go ahead. No. Okay, here in the front.
Number 2 then.
Number 2.
Number 2?
Go ahead.
Yes.
Hi, Ace Robinson, Los Angeles. Great paper, thank you. Quick question for the men that you were working with. Did you were you able to segregate them from heterosexual and homosexual and bisexual, and what were the characteristics therein? And then also, were you able to ascertain the level of sexual education that the men had received, either in primary school or secondary?
Thank you. So just to respond, we did not look at gender identity, and we didn't look at sexual education, so I can't respond to those questions. You have a follow-up?
Sexual orientation.
Sexual orientation, yes. We didn't look at that.
Mariam Shamanish from UCL.
Hey.
Hi, how are you? So just, maybe I missed it, but I wasn't very clear how the definition of risk was. Risk of what?
Risk of acquiring or transmitting HIV.
By virtue of having, did you have incident HIV data that was linked to?
No, I think the purpose of this is more to direct programming towards certain groups, and so based on the risk behavior variables, which is self-report, it's not sort of hard outcomes. But you could actually use hard outcomes if you had them. We didn't have them in this survey, but you could use them as part of latent class analysis, certainly.
Okay, final question. Please introduce yourself.
Wim Delva from Sasima in South Africa. I had a similar question around the risk of acquiring or transmitting HIV. And so in my understanding, the label that you used to name these 4 groups doesn't come in a strict sense directly from the data, but it's how you interpret this combination of all these variables.
That's
and so
exactly
I think
right.
it might be confusing. Also, we didn't hear anything about differences in sex frequency, condom use, and lastly, the risk probably depends on the profile of these female partners, which we also didn't really hear about. So I think it's potentially dangerous to make these strong statements about low versus high risk.
Yeah, thank you. So LCA, the purpose, if anyone's done factor analysis before, it is quite based on the researchers' interpretation of the groups. However, it's also data-driven, in that you can clearly see the profiles of the groups, the percentages in each group, the service uptake, et cetera. So in that way, it is rigorous, but from an epidemiological standpoint with hard HIV outcomes, that kind of thing, it might be considered less rigorous. But we still believe it can be very useful for directing programming and for decision-making on the ground in terms of who you're trying to reach with exactly what programs. And I'll just respond to the condom use question. So condom use we had initially tried to include it in the model, but it didn't differ across groups. Unfortunately, it was extremely low at about a third having consistently used a condom with their last partner. So in LCA type analyses, it's still obviously important to take into account factors that don't necessarily differ between the groups, but are concerning across the groups.
Thank you very much, Anne.
Thank you.
I'll now turn over to Linda-Gail to introduce the next speakers.
Great. It's my great pleasure now to ask Alison Roger to go to the podium. She's from University College London, and she'll be telling us about Partners 2.
Thank you. I'd like to say thank you to the organisers for allowing us to present our data here today. Looking at HIV transmission risk through condomless sex in gay couples when the positive partner was on suppressive ART. So I have no conflict. So there's very clear evidence, particularly in heterosexual couples, of the dramatically reduced risk of HIV transmission from condomless sex when the positive partner is on suppressive ART. And although the bulk of the evidence is in heterosexual couples, there have also been 0 cases of HIV transmission reported in recent observational studies in gay male serodifferent couples, and that includes Partner 1 in 2016 and Opposites Attract, which published a few weeks ago. But if we look at the precision around these estimates of 0, with a couple years of follow-up accumulated to date in Partner 1, you can see that the upper limit of confidence around that estimate was 0.84 per 100 couple years of follow-up, and that was almost double the upper limit of confidence of 0.46 in heterosexual couples. So the primary aim of Partner 2 was to provide more precise estimates of transmission risks in gay partnerships with suppressive ART, and really to provide equality of evidence for gay men as we had for heterosexual couples. So the Partner study is an observational multi-centre study of HIV serodifferent couples, both heterosexual and gay men, in which the positive partner was an ART. And this was in 75 European clinical sites in 14 countries. So the study was in 2 phases. Phase 1 from 2010 to 14 recruited and followed both heterosexual and MSM serodifferent couples, whereas Phase 2 from 2014 to 18 followed gay male serodifferent couples only. So the primary aim of Partner 2 was to estimate the risk of within-couple HIV transmission through anal sex during periods when condoms were not used and the positive partner was on suppressive ART. So in terms of study procedures, study staff were asked to emphasise at each study visit the need for consistent condom use. And the informed consent included explicit reference to the fact that the HIV-negative men knew their partner was HIV positive, and there was the potential for transmission if they didn't use condoms. So we collected study data at baseline in every 6 to 12 months, and that included a confidential, self-completed sexual behaviour questionnaire completed by both partners, HIV testing for the negative partner, and HIV viral load measurement for the positive partner. And some of the data items we collected are in the table, as you can see. So a couple years of follow-up were eligible for inclusion in this analysis, basically formed of periods of time between testing for the HIV-negative partner, and also if the couples had condomless sex together during the time period. There was no reported PEP or PrEP use by the negative partner. The positive partner had suppressed viral load defined as less than 200 copies within all time points during that period, and then follow-up occurred before the end of April this year, which was the censoring date. So we report here the rate of within-couple phylogenetically linked transmissions during eligible couple years of follow-up. So we obtained sequences in those who had a detectable viral load, either through HIV RNA from plasma or those with suppressed viral load through HIV DNA from PBMCs by Sanger sequencing, and we complemented this by deep sequencing by Illumina in a subset. So we determined maximum likelihood in Bayesian Markov chain Monte Carlo inferences and their relevant statistical supports using the software listed on the second bullet. So we obtained control sequences from 3 sources. The 10 closest sequences identified through a blast search of GenBank. We used replicate partner sequences, and this was either repeat testing of the same sample, testing of different types of samples, or from different samples from different time periods. And we also used control sequences from other studies from confirmed HIV transmission pairs. So a seroconversion event was classed as linked if there was monophyletic clustering with high statistical support, and this was defined as a bootstrap value of greater than 0.9, posterior probability greater than 0.95, and a pairwise genetic distance of less than 0.015 nucleotide substitutions per pol site, and this is as per published methodology. So in terms of eligible couple years of follow-up, we recruited almost 1,000 gay serodifferent couples, of which 783 couples contributed 1,596 eligible couple years of follow-up. So we didn't include 477 couple years of follow-up in this analysis for the reasons listed on the bullet. 32% reporting no condomless sex, use of PEP or PrEP in 24%, or viral load data not available or missing data on whether they'd condomless sex. But reassuringly, we lost only 5% of couple years of follow-up because the positive partner's viral load was measured at more than 200 copies, indicating very high levels of virological control in this cohort. So if we look now at some results in terms of the HIV-negative partner characteristics, Median age at entry was 38 years, predominantly white ethnicity at 89%, and they'd been having condomless sex with their HIV-positive partner for a median of a year. During follow-up, almost a quarter of HIV-negative men were diagnosed with an STI. 37% reported having condomless sex with other partners outside the main study relationship. And overall, couples had condomless sex a median of 43 times per year, so 3 or 4 times per month. But we accrued a very large number of total condomless sex acts, almost 77,000. And in the absence of ART, we would have expected a very significant number of transmissions. So just to put it in context, the HIV-negative partner reported having receptive condomless anal sex with their positive partner 42,000 times in total. And in the absence of ART, we would have expected almost 500 transmissions to have occurred. So we look at positive partner characteristics. Again, median age was similar. They'd been on ART for a median of 4 years. Self-reported adherence was extremely high. And during follow-up, adherence remained high, with only 2% reporting that they missed ART for more than 4 consecutive days. And as per the HIV-negative partners, a quarter reported an STI during follow-up. So in terms of new infections in the negative partners, 15 initially HIV-negative gay partners became HIV-positive during follow-up, of whom 11 reported recent condomless sex with other partners. Samples were collected from both partners within a very narrow time frame, a median of 0 months apart. And we recovered viral sequences successfully from all couples, 100% for Paul and 87% for Em. And all of these new infections were not phylogenetically related to the initially positive partner's virus. So you can see 15 HIV-positive partners all had subtype B infection, and 6 of the 15 newly seroconverting partners acquired non-B infections. And in all the phylogenies, none of the partner sequences in blue clustered together, and this was consistent across all analysis. In contrast, the study controls consisting of replicative partner sequences in red and control sequences from known transmission pairs in orange always clustered together with very high supports. So the controls pairwise genetic distance was 0.04. They always clustered together on a monophyletic branch. I know it's hard to see, but it's the red and orange clusters on the phylogenetic tree to your right. And this was as posterior probabilities equal to 1 and bootstrap values greater than 0.98. While the partners' pole sequences showed a median pairwise genetic distance of 0.068, and moreover the pairwise genetic distance was always greater than 0.04, indicating that the sequences were not linked. So these are really the main results of the study. So you can see here sexual behaviour on the left, number of linked transmissions, upper at 95% confidence interval, couple years of follow-up, and condomless sex acts accrued during follow-up. So obviously with zero linked transmissions across all types of sexual behaviour. In terms of the upper limit of the confidence interval indicated by the end of the bar, you can see we now have very narrow estimates around any sex and anal sex. We had less couple years of follow-up for individuals having sex with an STI at only 135, and the limits are actually greater, again related to the number of couple years of follow-up, but we had 0 transmissions even during 135 couple years of follow-up and 6,000 condomless sex acts during a period of having an STI. So looking at this slide as to whether partner 2 met the primary aim, and that was to provide equivalence of evidence for gay men as we have for heterosexual couples. So you can see at the end of the partner 1 study, the upper limit of estimate around 0 transmissions was 0.84 per 100 couple years of follow-up, almost double that, the confidence interval for heterosexual couples, purely as a function of not having sufficient couple years of follow-up. So by extending recruitment and follow-up in partner 2, we now have a very precise estimate of 0.23 of the upper limit of confidence. And that really, at the worst case scenario, you would have to have condomless sex for 419 years to even have the possibility of 1 transmission. So I think we can say this is effectively 0. Thank you. So in conclusion, among serodifferent gay couples who had sex 77,000 times without condoms, with undetectable viral load, we found 0 linked transmissions during almost 1,600 couple years of follow-up. Our results give equivalence of evidence for gay men, indicate the risk is effectively 0. Undetectable equals untransmissible. Thank you.
Our crowd loves good news. This paper is now open for questions. It seems that the microphone is here at number 2, so I'm sorry if you're in that corner, you have a long walk to the mic. But if you can just make your way as quickly as possible, that would be great. Okay. Super. Just if you can keep your questions quite short, because we still have 2 papers, so and try and limit, I think, to 1 question if possible.
Am I going? Thank you very much. Wonderful news. I'm just wondering, what do you think about the difference in subtype? So, do you feel like these are going to translate to subtype C? Thank you.
They were really CRFs. I don't have all the virological data, but they were different subtypes. All the initial partners were Bs, and all 6 of the others had non-B subtype.
Thank you.
Thank you.
Next.
A brilliant study. Thank you. Given so much of the world only has access to DBS, qualitative viral load, with a sensitivity of 1,000 copies, do we have any data from partner 1 or partner 2 about the risk for those patients who fall below between the 200 and 1,000 threshold on viral load?
I mean, this was very late-breaking data, and I don't have all the information, but from what we can see, there were no linked transmissions, but I really don't have the data, so I'd really rather just prefer talking about the eligible couple years of follow-up, but we will be reporting on that data.
Great, thank you.
Thank you.
Thank you.
Perhaps just say who you are.
Hi, I'm Lori Sela from Seattle. A lot of the resistance among clinicians to changing their recommendations is based on the concern of how do you know somebody hasn't become detectable. How frequently do you think viral load testing is needed for monitoring people being undetectable?
Well, everyone's different, aren't they? I mean, we all know as clinicians we have patients who need more frequent monitoring, but somebody has been suppressed. I mean, you can see these were couples who were established in ART for 4 years, and there were very low numbers that actually number of copies went above 200. So it really depends on the patient population you're dealing with. But in our population, when someone was suppressed, they stayed suppressed.
Thank you.
Okay.
Mike.
Terrific. Mike Cohn from the University of North Carolina. Terrific job, Allison. Okay. Congratulations. I have a really quick question. The one thing we worried about, you indicated the men had been on ART for 4 years, I think, as a median. But did you have men who were newly starting treatment? And how did you manage that window where we've worried about that window where we occasionally can see a transmission event?
Yeah, I mean, it's a partners prep data. You're referring to the 6-month cutoff.
Yeah, well, the number. But in general, though, did you have new starters?
Well, we did have people that had been on for a couple of months, but we didn't include eligible couple years of follow-up unless they were suppressed. And I think even looking at the partners prep data, it's the fact that they weren't suppressed that was the issue. Yeah.
Thank you. Congratulations.
Thank you.
Mm-hmm. Thank you very much. I'm Masazumi Yamaguchi from Tokyo, Japan. How many percentage in your cohort use drugs?
There were quite low levels of drug use. I mean, we found in partner 1, more in the heterosexual couples, there were higher levels of drug use. And again, very low levels, but we will report on that data. But again, there were no transmissions.
Okay. Thank you.
Thank you. Oh, it looks like we've got one more, and it has to come from U equals U himself.
Hi, Allison. Today is marking a revolution in what it means to live with HIV. So thank you so much for your research. I have a question on behalf of the U equals U campaign. There are many providers that are still not accepting this message. They try to focus on the risk is not zero scientifically, or they focus on their patients aren't going to be adherent and they won't know that they're detectable, or they say there's a rise of STIs already, so they don't want to share this with their patients. We get every single kind of excuse. What would you say to clinicians or any other information provider who is withholding this information from people with HIV?
Yeah, and I just want to pay tribute to the U equals U campaign. It's been astonishing. I think the time for excuses are over. I think it's very, very clear that the risk is zero. So I very much think we have to promote this. I think if you're on suppressive ART, you're sexually non-infectious, and yeah, the time for excuses is over. And I again pay tribute to you and your work. Thank you.
Well said. Thank you, Alison. Great. So we're going back to country level data, and it's my pleasure to ask Dr. Moketsi Joseph Makema from the Botswana Harvard AIDS Institute Partnership to report on the Yatsi Botswana Prevention Project.
Shall I have my slides? Where are they? Okay. Just click on yours. Okay. This one's. Okay. Thank you, Chair. We thank the organizers for the opportunity to present our findings on the Botswana Combination Prevention Project, or we call it the Yatsi study, an impact of prevention and treatment on population HIV incidence. We wish to begin by acknowledging and thanking the people living with and affected by HIV who participated in our research. I have no conflict of interest. The Yatsi or Botswana Combination Prevention Project was a pair-matched community randomized trial in 30 communities in Botswana, 15 of which were in the intervention and 15 in the standard of care arms. It was designed to evaluate the impact of a package of HIV prevention and treatment interventions on population level HIV incidence. We had baseline and annual surveys being conducted in adult residents of a random sample of approximately 20% of households in all 30 communities to evaluate 1, HIV incidence, 2, uptake of components of interventions over time. The interventions were scaled up quite rapidly in the intervention communities following the enrollment of the HIV incidence cohort at baseline. We started the study in October 2013. It ended in March 2018, and scheduled follow-up was completed in June 2018. And today I shall be presenting the primary HIV incidence results by randomized arm. The interventions were as follows. In the intervention communities, we did 1, community mobilization, secondly, intensive home-based mobile testing campaign and mobile testing campaigns, which were followed by targeted testing. We also did support for linkage to care, which included scheduled clinic appointments, SMS appointment reminders, and active tracing. We also offered expanded antiretroviral treatment in the intervention arm, with criteria for antiretroviral treatment initiation changing over time. We offered universal treatment, which started in June 2016, and at that time, we started treatment at the first clinic visit. And prior to June 2016, expanded antiretroviral treatment was offered according to the criteria that is listed on the slide. In the 15 standard of care communities, antiretroviral treatment was provided as per national standard of care to persons with CD4 count less than 350 or who had WHO stage 3 or stage 4 disease or were pregnant until June 2016, when universal antiretroviral treatment became the standard of care in Botswana. I think it is important for us to emphasize that the interventions were actually provided at the clinics by the appropriate typical cadres of staff at those clinics. This is a map of Botswana depicting the communities that participated in this study. Overall, the participants were up to 180,000, which is nearly about 10% of the Botswana population of 2 million. The next slide is a schematic of the study. As we said, a primary study endpoint was cumulative HIV incidence, which was measured in an HIV incidence cohort, which is highlighted in this slide within the red box. This HIV incidence cohort was followed prospectively and was evaluated and tested for HIV during 2 subsequent visits over a period of approximately 30 months. We started the interventions in the intervention communities shortly after enrollment of the HIV incidence cohort after the baseline survey. We were able to enroll 4,487 participants, HIV-negative participants, in each arm. The retention was high, with 96% of the cohort in the standard of care arm and 95% in the intervention arm retesting for HIV during at least one follow-up visit. The baseline socio-demographic and HIV-related factors were similar in both arms, and 60% of our participants in the cohorts were female, with a median age of about 30 years. The HIV prevalence and baseline 90-90-90 cascades coverage were similarly high in both arms, with 70% of all HIV-positive individuals with viral suppression at baseline. And now for the primary results. 57 participants in the intervention arm and 90 in the standard of care arm acquired HIV, yielding annualized HIV incidence rates of 0.59% in the intervention arm compared to 0.92% in the standard of care arm. The pre-specified primary analysis of treatment effect was a permutation test from interval-censored Cox proportional hazards models. The primary analysis gave an unadjusted incidence ratio of 0.69 for HIV incidence in the intervention compared with the standard of care arm, with a p-value of 0.09. We also did additional standard pair stratified Cox proportional hazards models analysis to obtain 95% confidence intervals, and these yielded an unadjusted incidence ratio of 0.65 with a 95% confidence interval of 0.46 to 0.9 and a p-value of 0.01. Results of these analyses were adjusted for covariates, which are described in the footnote in the lower 2 rows of this table, and they yielded similar results to unadjusted analysis. Additional analysis accounting for the negligible intra-class correlation that was observed resulted in similar confidence intervals, and these were 0.43 to 0.95 and a p-value of 0.03. And in summary, the results of all these analyses are consistent, and they indicate at least 30% reduction in HIV incidence associated with the intervention. This slide depicts a map of HIV incidence by community and randomized arm, with standard of care communities marked in red and the interventions marked in blue. And the size of the dots is scaled to the annualized HIV incidence. And as you can see, the annualized HIV incidence was quite variable by community, and it ranged from 0.23 to 1.81. The next slide shows estimated survival curves with 95% confidence intervals for time to seroconversion in the intervention arm, which is shown in blue, and the standard of care arm shown in red. And these curves support the results of the primary analysis. We further, to ensure that we enhance interpretation of our findings regarding HIV incidence reduction, we are sharing one overall measure of intervention coverage that was achieved over time by randomized arm. And specifically, we determined the proportion of all HIV persons. These are both who were previously known to be HIV positive and those who were newly diagnosed with HIV, who had viral suppression at baseline and at study end, and we are also presenting them by randomized arm. And therefore, by end of the study, we had an additional 18% of HIV positive persons in the intervention arm versus 7% in the standard of care arm having viral suppression. And that was also statistically significant. So, as per the overall cascade, 88% of all persons identified with HIV in the intervention arm had undetectable viral load versus 82% in the standard of care arm. In conclusion, we observed a 30% reduction in community HIV incidence with a combination of community-based HIV testing, linkage to care, and antiretroviral treatment interventions. And we believe it is possible to increase antiretroviral treatment coverage and reduce HIV incidence in a high generalized epidemic, even when we have very high baseline antiretroviral treatment coverage. I would like to acknowledge our funder, PEPFAR, the incredible teams that did the study, from the Botswana Harvard AIDS Institute Partnership, the Harvard T.H. Chan School of Public Health, the Centers for Disease Control and Prevention, the Ministry of Health and Wellness in Botswana, our various implementing partners, and most importantly, our study participants. Thank you.
Some more good news. Is there anybody who would like to ask a question? If you could come quickly to the mic. I think that was very clear indeed, Dr. Makema, so thank you very much indeed.
Thank you.
Some good news. Right, and thanks, Diane. If you'll go to the podium. We are delighted to have Diane Havler present the last paper in this session. She is from the University of California and is here to give us the primary data on the well-known search study. Over to you, Diane.
While we're getting the slides up, I'd like to thank the organizers for inviting us to present our results today. So the approach, the search study is one of the large test and treat trials that's been conducted in sub-Saharan Africa over the last 5 years. The approach that we took in search was to approach HIV test and treat through a multi-disease community health approach versus HIV only. The specific hypothesis that we sought to test was that HIV test and treat with universal ART using a multi-disease, patient-centered care model would reduce new HIV infections and improve community health compared to a country guideline approach. To test our hypothesis, we conducted a pair-matched, community randomized study of 32 rural communities of 10,000 persons each, shown here on the map. Our study population was those age greater than 15 years older, and we did a comprehensive baseline census. This study summarizes our study interventions, shown here in blue for the intervention communities and orange for the control communities, and I'll use these colors throughout the presentation. For HIV and non-communicable disease diagnosis, we conducted health fairs with follow-up testing for those non-participants at baseline and annually. We did health fairs at baseline only, and we reported on these health fairs previously. We conducted these fairs in the community with the community input and offered diagnosis for HIV, hypertension, diabetes, diagnosis and treatment for malaria, and other diseases. ART eligibility was universal from day one in our intervention communities and evolved over time according to the country guidelines in our control communities. Our care delivery was a patient-centered chronic care model in our intervention communities with rapid ART start and viral load counseling, a welcoming environment, flexible clinical hours. Our control community received care for HIV and non-communicable diseases according to the country standards. We had a wide array of study endpoint measurements, including HIV cascade, community health, and HIV incidence, shown here in the order I will be presenting them. Just of note, viral suppression was measured using the Roche assay, with suppression defined as less than 500 copies per mil. Mortality was measured using comprehensive key informant interviews at year 3, classified as due to illness, childbirth, suicide, or accident. Our primary endpoint, HIV endpoint of cumulative 3-year HIV incidence, was measured using rapid antibody testing with Genius and Western blot confirmation at year 3 health fairs among 117,000 persons HIV negative at baseline. For randomization, we pair matched on region, population density, number of trading centers, occupation mix, and migration. We were powered to detect a 25 to 40% reduction in 3-year cumulative HIV incidence. And our comparison of outcomes between arms was using a community level analysis. And we used TMLE and pre-specified adjustments to improve precision. And we had pre-specified sensitivity analysis to look at the robustness of our findings. Our study was conducted between 2013 and 2017. As you know, during this time, global and national guidelines rapidly evolved. This graph shows what happened in our control clinics during the course of the study. When we started the study, ART eligibility in our control clinics, and this is where we were working, with CD4 less than 350. This is shown here for Kenya. But within 1 year of the study, this rapidly changed for eligibility, expanded to CD4 less than 500, plus a wider grade of inclusion groups, which was nearly universal. And then at the end of the study, universal ART was implemented at the study sites. These are our results. At baseline, we enumerated 355,000 individuals. About half of those were less than 15 years of age, leaving us with 150,000 baseline residents. During the course of the study, 26,000 aged into our cohort and 25,000 in-migrated into the cohort, and 2,600 died and 13,000 out-migrated. So here's some characteristics of the overall study population of 150,000. The HIV prevalence among regions differed. In Kenya, it was 19%, in Western Uganda, 7%, and in Eastern Uganda, 4%. About a 20% prevalence of hypertension. Half of our populations were farmers, and male circumcision was 30%, 34% across the board in our study population. So this slide summarizes the proportion ever tested for HIV. So when people entered into our health fairs and campaigns, about half of them said they had been tested previously. We did our health fairs in both intervention and control arm here, shown in the blue and orange, and as you can see, we reached over 90% of all persons over 50 in these baseline campaigns. Then we continued to conduct annual campaigns in the blue, shown here, and had incremental increases in coverage up to 94% at 2 years. So when the study started, about 50% of individuals in both the intervention and the control arm were already on ART. What this slide shows is ART start among baseline HIV-infected persons who were not on ART at start. So what you can see is there's a more rapid ART start in the intervention versus the control arm. We also saw more rapid ART start in the intervention versus the control arm in all CD4 strata, including less than 350 when everyone was eligible at the start of the study. 80 versus 45% had started ART in our intervention versus control arm in this strata at year 1, respectively. This shows viral suppression, population suppression among all HIV-infected persons over time. These are conservative estimates that include in migrants. And you can see the 2020 UNAIDS target of 73% for a referent. At baseline, coming into the study on a population level, about 40% of persons in HIV infected were suppressed in the intervention and the control arm. What you can see is by year one, we essentially reached the UN target, and then this increase in the intervention over time that we were measuring at our annual campaigns. Then at year 3, we measured population level suppression in our intervention versus control arm. You can see it was about 11% higher in our intervention versus control arm, which was statistically significant. In pre-specified subgroups of women, men, and youth, suppression between intervention and control was also about 10% higher. In women in our intervention arm, population level suppression was 81%. In men, it was 74%. In youth, it was 55%. And if we just include people who started the study not in migrants, these numbers are about 10% higher. So what did this achieve, this rapid scale up in terms of impact on community health? Well, when we looked at mortality among the HIV population, mortality among HIV-infected persons was 21% lower in our intervention versus our control arm. On an entire population, mortality among all persons was 11% lower, borderline statistical significance. You can see the 95% confidence intervals, 0.79 to 1.02. Another important community health outcome was tuberculosis. HIV, TB, or death among HIV positives was 20% lower in our intervention versus control arm. When we looked at annual TB rates among HIV positive individuals at baseline, at year 3, TB annual incidence was 59% lower in our intervention versus our control arm. Finally, non-communicable disease control was much better in our intervention versus control arms. Here, I share with you the results of hypertension. On a population level, hypertension control at year 3 was 26% higher in our intervention versus our control arms. We saw greater control, not unexpectedly, in our HIV-infected individuals if we looked at the combined output, and also when we looked at hypertension and diabetes. So this is what we saw in terms of community health outcomes. What did we see in terms of HIV incidence? So we saw no difference in 3-year cumulative HIV incidence between the arms, 0.8% overall, and you can see no difference in our regions of Kenya, Western Uganda, and Eastern Uganda. So why did we not see any difference? Well, certainly the most plausible reason is we had a very, very active control and search. As I mentioned, 90% of persons were aware at their HIV status in these baseline health affairs that were very well attended. And in line with what we had planned in our study, we rapidly implemented new guidelines in the control communities, and ART eligibility was near universal within 1 year. A mathematical model that incorporated these high levels of viral suppression in our intervention and our control arms predicted a 10% reduction in incidence between the arms, which we may not have detected. That's one explanation. It's also plausible that you could see these results if all the new infections were coming from outside the communities, they were from acute infection outbreaks, or from a small subset of unsuppressed individuals. We're testing these hypotheses in ongoing phylogenetic analysis. So we didn't see any difference between arms, but it's possible it could be because HIV incidence declined in both arms over time. And we were able to measure this in our intervention arms. And indeed, we saw a 32% decline in annual HIV incidence from year 1 to 3 in our intervention arm. We saw a 45% decline in Kenya. And as others have reported, these declines were greater in men than in women, a 49% decline in men and a 19% decline in women. Well, we really did not have a true control arm in search in terms of we offered these baseline health fairs and campaigns for all of their individuals. So let's turn to modeling to say, what would have happened without these baseline campaigns, a true control, if you will. And the black line here is what one would have expected with changing guidelines, with ramp up of circumcision, and that one would have expected at year 3 to see an annual HIV incidence of about 0.7%. The model predicted with search that we would have seen about a 0.3% incidence, and this was very close to our measured incidence. So I think this all supports that the whole search intervention was associated with a reduction in HIV incidence. So in summary, a multi-disease community health approach with patient-centered model rapidly increased population suppression from 42 to 79%. In our comparison of our intervention versus control, we saw a 21% reduction in mortality, 59% reduction in HIV/TB annual incidence at year 3, and a 26% increase in population level hypertension control. And our explanation for this is the search intervention. We did see reduced HIV incidence, 32% reduction in annual HIV incidence within arms, but we did not see a difference between arms. Our explanation is our active control, or as I mentioned, there's other plausible explanations for this. So in conclusion, the search model worked. This multi-disease, patient-centered approach can be adapted to accelerate reductions in mortality, in TB, and new HIV infection synergistically with improved non-communicable disease control in line with the Sustainable Development Goals. We didn't totally eliminate new HIV infections, and that is one of our goals. To do this, we're going to need to increase viral suppression among youth, better understand transmission dynamics, which may vary among regions, and integrate new treatment and prevention interventions efficiently and effectively in what we think is a multi-disease and financed approach. So I'd like to thank and acknowledge my co-PIs for the study, Dr. Moses Kanya, Dr. Meyer Peterson, our statistician, Dr. Laura Balzer, our vice chair, Dr. Edwin Charlebois, our virologist who couldn't join us today, Dr. Terry Liegler, all the members of the search team, many of whom are here today, and most importantly, the communities that we serve, and of course our funding agencies. Thank you.
Diane, I'm sure the audience will agree. Congratulations on an awesome amount of work. So we're very pleased to see these results. Please, microphone to you.
Hi, Stanley Way, US CDC. I'm just curious about how PEDS kids under age 15 were handled in the intervention, whether they got any different intervention, either by design or by spillover when there were fairs or visits to homes.
Thank you for asking that question. The search approach was for the entire community. We've presented previously, and so we did HIV testing for children, and we have not completed analyses of those data, but we're hoping to sharing those data. But children were treated and were given universal treatment.
Thank you. Next.
Yeah, Ruben Granish, consultant. Thank you for a great study. It's a huge amount of work. We really appreciate it. I have one comment and a question. Basically, the comment is what do you think that it will take, or the question is, what do you think that it will take to scale up the multi-disease prevention approach that you've actually before? Because it looks to me like it's very, very successful. It's been done before, and what will it take to actually scale that?
I think that we are a community that uses evidence to guide our policy and decision making, and I think the search study, we hope, provides evidence for policymakers that this is a way that we can rapidly scale up ART, reduce mortality in settings with a wide array of HIV prevalence.
Cristina Mussini, University of Modena, Italy. Just a question about tuberculosis, the decrease in the incidence of tuberculosis. Did you give isoniazid to both populations?
Thank you for asking that question. We talked about that when we were designing the study. What we chose to do was to allow the country standard to occur during the course of the study. During the course of the study, isoniazid use was very, very low in both countries. As you know, recently Kenya has had just remarkable success in scale-up of isoniazid, and this was really after our study, the primary part of our study occurred. Thank you for that question.
Next question.
Dennis Nash, City University of New York. Thanks for these findings and a great, I know, long study. It was a ton of work, and it shows. I'm wondering if you can say something about, I mean, we really necessarily wouldn't expect a big difference in incidence unless the people in your intervention communities are getting on treatment much earlier than they otherwise would have, say, compared to the control community. So do you have a sense of like the median CD4 at treatment initiation in the intervention communities versus non-intervention communities? I'm wondering the same about the Botswana trial too.
How can I say, we have CD4 data at baseline, and we had rapid ART start across all CD4 strata in our intervention and in our control arm. So I think that's what I can address for that question.
Thanks. Last question.
Hello, Elske Hornenborg from the Public Health Service of Amsterdam. Very impressive result, thank you. We do know that there is sometimes a problem with supply of medication, availability of medication in some communities. Was there a difference in the availability of ART in the intervention clinics and the standard clinics?
There was not, from the standpoint, when we did the study, we did not want to test whether manpower shortage or drug shortage would be the reason why we saw a difference. So in our control communities, we ensured they were provided extra staff so that they could both ensure country of standard of care and also rapidly implement the guidelines.
Thanks. This is absolutely the last one.
Thank you so much. Emily Bass from AVAC. Thank you for the results, and Diane and all the work in leadership. Can you talk about primary prevention coverage and things, because you were working to get PrEP in and male circumcision, and any differences or just sort of what happened with those two pieces?
In terms of, sorry, can you say it again?
Primary prevention, so male circumcision and PrEP in intervention versus control.
Oh, sure. Okay. So adult male circumcision increased about 10% during the course of the study in both arms. In the second phase of search, PrEP was not occurring at the time during search. In the second phase of search, we are using what we've learned in phase 1 to identify those individuals who might most benefit from PrEP. And so we're continuing on and hoping to share those results with the field.
And on that note, I want to thank this amazing array of science and speakers and hand back to Peter.
Well, just want to thank the speakers as well, but also the audience for staying and apologizing for running late, and also for your active participation. So enjoy your short lunch, and then we'll see you back for the next session. Thank you.